is Dr. Revital Kariv, as a long-term friend of mine and our team. And Revital is a professor of the medicine at the University of Tel Aviv. And she actually published the first controlled study in pouch neoplasia 14 years ago, or 12 years ago. And then, so her topic is surveillance and management of the pouch neoplasia in IBD and FAP. And Revital, welcome.
Thank you very much, Bo, organizers. It is my honor and pleasure to be here with you. The International Pouch Consortium has dedicated a separate issue to pouch neoplasia that comprehensively reviews the literature and also bring expert opinion on a key clinical topic that have no supporting data. This paper also highlights the needs to a multidisciplinary discussion teams and highly personalized approach. So this is our agenda for today. We'll discuss a little bit of pathophysiology, classification, risk factors, incidence, and then separately pouch dysplasia for IBD and FAP, then to converge all together to pouch cancer for both condition and pouch surveillance. So as you've heard yesterday from Dr. Church and from Dr. Ko just now, both IBD and FAP carry high risk for cancer in general and in the pouch. The evolution of pouch neoplasia differs in these two conditions. You just heard a very detailed explanation from Dr. Ko. So in IBD, we have the inflammation dysplasia carcinoma sequence, while in FAP, we have the classic adenoma to carcinoma transformation. I will not give any more details, as you've heard enough. But just to bear in mind, in each of these conditions, there is a complex interplay between genomic background, microbiome with pouch stasis, and some environmental exposure. So very highly complex individual neoplastic arena for each patient. As we heard today, the small bowel mucosa in the pouch is not real small bowel mucosa. It is getting transformed to kind of a millicolon. So the small bowels tumors or neoplastic lesions are not really like a small bowel lesions. Colitis-associated neoplasia has shown similarities to IBD pouch neoplasia. In addition, neoplastic pouch surgical specimens support the sequence of inflammation, dysplasia, and cancer. Neoplastic pouch lesions do not show excess of mismatch repair deficiency. And in addition, as you just heard from Dr. Ko, the adenoma to carcinoma spectrum is not fully manifested, especially in IBD, but also not in FAP, sometimes due to buried mucosal islands, as we know. The last point is kind of funny, but I thought to put it here. So IBD is a common condition, and some of our FAP patients do develop IBD either before or after pouch surgery. I personally have 3 such patients. This is something to bear in mind. As to pouch classification, this is highly important for risk stratification and management and should be very detailed and specific. We should address the cell type, either glandular, small or large bowel mucosa, squamous, lymphocytic, or neuroendocrine, the location, exact location in the pouch. Endoscopic morphology is important, and there are several systems of classification out there. Histology, as you heard, either low or high-grade dysplasia, multifocal, unifocal, and current and historical additional lesions, metachronous or synchronous, polyps, or cancer. So, as I just mentioned, the endoscopic classification is highly important. We were discussing yesterday that advanced lesions often are not biopsies to prevent fibrosis. And so the detailed endoscopic report with either a Paris classification could or may be problematic, but the classified lesion is very important and sometimes replaces the biopsy's results. Pouch lesions tend to be flat and sometimes lateral spreading. Biopsies should be taken around the lesion. This is highly important. And also a second revision from a GI expert pathologist is required in dysplastic lesions and above. What are the risk factors for pouch neoplasia? So we consider the risk factor for colitis-associated neoplasia as valid also for pouch neoplasia, and these include the duration of IBD, family history of colorectal neoplasia, PSC, and environmental exposure. In addition, specific risk factor, which has been shown as a major risk factor for pouch neoplasia, includes preoperative colitis-associated neoplasia and other factors that support chronic ongoing inflammation in the pouch, such as chronic pouchitis, caphitis, and Crohn's disease of the pouch also matter. As for FAP, we do not really know what are the risk factors for pouch polyps and cancer, but several cohorts have described some factors that include the type of APC mutations, if it is in the MCR region, if it is a bad mutation like a deletion, that is more associated with pouch polyp. And also pre-surgical cancer has been shown as a risk factor, and some factors that support a more severe FAP phenotype. That is a bad family phenotype and the upper GI involvement of stomach and duodenum in polyps, and also desmoid tumors. All these suggest more severe FAP phenotype and are also associated with pouch neoplasia. What are the prevalence and incidence of IBD? So the two largest cohorts that have been described for pouch neoplasia includes the 2010 CCF cohort and the Dutch pathology database 2014, and both of them describe between 1.2 to 1.8% of overall pouch neoplasia, with 0.3 to 1.3% of pouch cancer. The National Danish Cancer Registry has been showing, though, a much less rate of pouch cancer. A systematic review of 49 cancer has shown rates that are similar to the CCF cohort of 0.35% cancer over 20 years. And the right panels shows the cumulative incidence of pouch dysplasia in IBD between 5 to 25 years post-surgery. These are pretty similar, between the two cohorts, a little bit higher in the Dutch cohort. What is the natural history of IBD pouch dysplasia? So this study from the Cleveland Clinic 2014 describes that low-grade dysplasia actually persisted only at about 30% after about a decade of follow-up. This is also supported by other data that has shown reversal of multifocal low-grade dysplasia. On the other hand, high-grade dysplasia is not reversible and should promptly and definitely be treated. We need additional data to better be familiar with pouch dysplasia natural history. This complex algorithm is taken from the Pouch Consortium paper. I just like to highlight several important points here. One that has been discussed by Dr. Ko is regarding indefinite dysplasia in the pouch in IBD. So once that we get that answer, definitely optimization of medical therapy should be taken and rebiopsy, as well as a second GI pathologist review. The finding of dysplastic lesions in the pouch body in IBD has actually been divided by the Pouch Consortium to two major types. Lesions that are very well defined, polypoid, raised, and completely liftable. In the pouch body, these lesions are amenable to endoscopic resection, as opposed to the other one, ill-defined, flat, etc., that are more suitable to surgical management. But if we have similar polypoid liftable lesions in the cuff, The pouch consortium has advocated surgical local excisions to these lesions as opposed to the flat ones that are going straight for surgery. I dare to say that these subgroup may change in the near few years once we have more abilities and expertise in advanced endoscopic resections. As for FAP-associated dysplasia, so polyps are common in FAP patients. This is part of the disease. There is a cumulative 80% rate of polyps 20 years after pouch construction. We see it very often. We know there are some risk factors, as I've detailed before, and the management of pouch polyps has changed, as well as the management for intact colon in FAP. There has been a change of paradigm, mainly due to our better abilities to take out lesions by cold snares and advanced techniques. So once the endoscopist feel that the polyps are manageable and they are completely resected, one can follow endoscopically and manage these patients without the need for surgery. Once there is incomplete resection, obviously invasion or high burden, then surgical management is offered. Regarding chemoprevention, I don't have time today to get into details. I just mentioned that there are multiple negative studies. There was a positive, we discussed that yesterday, there was a positive study regarding the combination of sulindac and erlotinib for duodenal polyps in FAP. This New England paper has not shown the benefit for colonic or pouch polyps, but a later analysis did show some benefit to these patients. I would like to share with you really quick a recent experience that we had with advanced endoscopic resection for advanced dysplastic lesions in the pouch in FAP patients. This is from the last few months from 2 referral centers in Israel. So we have 7 FAP patients with 8 lesions. All lesions were laterally spreading lesions larger than 20 millimeters. And all cases were offered EMR as a first line of therapy. And the mean size of the lesions was about 30 millimeters. All patients underwent the EMR with 7 successful procedure. 1 failed due to fibrosis and then underwent ESD that was successful, and this was in the cuff. 1 of the 7 EMR that succeeded had local recurrence in the first follow-up colonoscopy. And I'm going to share this with you. This is one of the lesions in the pouch on the suture line you see here. And this underwent a EMR that was successful. This is the second case that had local recurrence after EMR. And you see it here, there's like the scar of the resection and nearby a villus lesion that was resected and then treated with soft coagulation. This is the ESD case that was successful in the cuff. Sorry about that. I'm getting to pouch cancer. As Dr. Ko mentioned, this is highly rare. We know that pouch surgery with and without mucosectomy does not abolish completely the risk for cancer, both in IBD and in FAP, and that has variable reasons, some buried mucosal island, the natural history of the mucosa, etc. You've heard that all. The rates that are reported vary. In different reports. For FAP, it is largely between 0.5 to 1.5%, and for UC, it is less than 0.5%. Patients with preoperative neoplasia, both FAP and IBD, carry higher risk for pouch cancer, and you can see the impressive odds ratio from several studies here. Pouch cancer are mostly glandular. You heard that from Dr. Ko. I will not elaborate more. You can read this in the Pouch Consortium paper. I was trying to group all the pouch cohort here in this slide, and this is actually the most recent one, the St. Mark's. And we have here the Cleveland Clinic and the Dutch that actually included only IBD, while the St. Mark's was using the St. Mark's Polyposis registry together with some IBD records. Danish registry included only IBD patients, and there is also a cohort from the Mayo Clinic with FAP patients. Most cancer have been diagnosed a decade or two post-surgery. The rates have been mentioned, and the 10 and 20 years cancer incidents are mentioned actually only in the Cleveland Clinic and Dutch reports. The management of pouch cancer is complex. Surgery is very challenging and carries high morbidity for both APR and pelvic exenteration. Anatomical plans are disrupted due to previous surgery and definitely may contribute to locally advanced disease. Neoadjuvant therapy is used and have been reported to have high success rate in the St. Mark's report. We don't have direct proof for that, but patients under surveillance seem to have more localized disease. Tumor board discussions are actually very important in these cases, and TNM staging system is used. Obviously, tumor markers and imaging are conducted pre and post surgery. The outcome of pouch cancer is rather poor, and I was trying to compare here the life table from both the Cleveland Clinic and the St. Mark's reports that is similar. It is 70% survival after 1 year. And the St. Mark's report shows 54 months median survival. As for pouch surveillance, briefly, this is very mentioned in detail in the consortium report. The standard test is pouchoscopy with random biopsies, three from each side. Image-enhanced endoscopy is encouraged. And due to the flat lesions, the endoscopies really has to be very focused in these endoscopies. We cannot really handle the buried mucosal islands. Maybe mucosal jumbo biopsies may aid in that. Regarding surveillance frequency, the pouch consortium advocate for IBD patients 1 to 3 years interval, depending on risk factors and history. Diverted and reconstructed pouches require surveillance. We advocate FAP pouches and annual surveillance. As has been mentioned here, a very high index of suspicion is required in these patients during surveillance for any symptoms, pouch stricture, pain, etc. There is no direct support for the benefit of pouch surveillance, but probably early detection has been supported by previous cohorts. As for future perspectives, so the frontier of chemoprevention hopefully will be evolving, and we will have less toxic agents. We know that terlotinib is rather toxic for our patients, so we don't have a good solution. And in addition, early non-invasive detection and prediction tests may contribute to surveillance and prevent missed lesions. And one example for that is this pre-published report that looked at whole genome methylation pattern in FAP patient between normal to dysplastic mucosa. So there was like an overall hypomethylation. And then between dysplastic mucosa to cancer, there was a focal hypermethylation, especially in promoters. In addition, the microbiome arena in relation to pouch neoplasia is not well understood as yet in both IBD and FAP, and hopefully can be manipulated. So to conclude, pouch surgery with or without mucosectomy does not prevent pouch neoplasia. Pouch surveillance is required at high volume specialty centers, and its full impact is to be shown. Low threshold of a suspicion for persistent symptoms in high-risk population is required. Advanced endoscopic resection techniques should be studied prospectively and collaboratively to define their safety and efficacy. Cancer of the pouch is rare and carries poor prognosis, and hopefully its management can be optimized in the near future. I'd like to thank my colleagues and you for your attention.